So first of all, if you don't know, if you aren't already a member of our community, Migraine Canada is a federally registered charity supporting the estimated 5 million Canadians who live with migraine and other headache disorders. Our mission is to improve the lives of Canadians with migraine and other headache disorders through our 5 pillars, which are advocacy, awareness, education, research, and support. And this is our most exciting time of the year because we've launched our 3rd annual Move for Migraine campaign. So June is Migraine Awareness Month. June 21st, coming up soon, is World Migraine Awareness Day. And at this time of the year, we have our annual awareness and fundraising campaign. We've dumped a lot of information on one slide for everyone to check out. You can go on our website. You can also scan this QR code. I'm interested to see how many people are interested in doing that to get more information of what the campaign is all about. You can check out this year, we have illuminations of national landmarks across the country. So at the bottom here in the purple section by province, we've let you know which landmarks where. I don't think it's included here, but I do want to point out the missing province, Saskatchewan. We have 2 or 3 confirmed landmarks as well. So we do this, we have the landmarks lit in purple, and we ask that you guys go out, check it out, take a picture of yourself, share it on social media, help spread the word, help spread awareness for the impact of migraine. Dr. Elizabeth Leroux is a neurologist and headache specialist. She currently practices at the Brunswick Medical Center Glen Neuro and is a faculty lecturer for McGill's Neurology Department. Dr. Leroux completed her neurology training at the University of Montreal and her headache fellowship in Paris, France. She directed the University of Montreal Headache Clinic from 2010 to 2016, after which she directed the CHAMP multidisciplinary program of the University of Calgary from 2017 to 2019. Dr. Leroux is past president of the Canadian Headache Society, the founder of Migraine Quebec, and the founder and chair of Migraine Canada. A well-known speaker for all audiences interested in learning about headache medicine and science, Dr. Leroux is passionate about education and advocacy for headache disorders. Her particular interests include multidisciplinary and holistic approaches, impact of migraine in the workplace, vestibular migraine, and cluster headache.
Okay, amazing, great. So good evening tonight. So it's it's a pleasure and an honor to present for you tonight. And if I have one hope is that during that presentation, you will learn something that will be helpful or supportive. So our title is Chronic Migraine. What is it? Can I improve? You know, how to revert from chronic migraine back to episodic. And I chose this little red toolbox there filled with tools because that's what we need, tools, all kinds of tools to improve. I do have disclosures regarding my work with the industry. So that those are the pharmaceutical companies. And some companies here are actually selling products that I will be mentioning tonight. So it's important that you are aware of this part of my work. And I also serve as the past president of the Canadian Headache Society, another group of very dedicated doctors who work for y'all. Kelly has already shown this, so I will not repeat all the statements. But it's very, very important because I am a specialist and I am a headache neurologist, but I'm not your healthcare provider. The other thing is I want to really emphasize that everybody's journey is different, and I want to be super respectful to everybody. If I say anything that confuses you or shocks you, that's not my intention. So I really hope that what I share will be useful for you. I will not, if there's any confusion, I really invite you or any questions that I'm not answering, please discuss with your healthcare provider. So we base this webinar on the questions from our community. So what's the difference between chronic and episodic migraine? And kind of subtitle, how is high frequency episodic migraine diagnosed? So I will cover that. Are there risk factors associated with migraine becoming chronic? Just a few words about medication overuse. Like when is that happening, and is withdrawal mandatory? So how can we prevent this famous chronification? What is it? And if you are in this chronic category, how can I improve? And I think that's a very important question that some people share with us is there a stage where nothing can be done? That's a question sometimes I hear in my office. So every day today, I saw patients and I discuss with them the principles I will share with you today. I try to focus on what is the most commonly discussed in my office with my patients. And I'm trying to make this kind of clear and useful for you. So I thought I would start with just a little preview of what I'm going to say so that each person with migraine needs a personalized plan. And by the way, some of you tonight might not have migraine. Maybe they have chronic tension type headache, post-traumatic headache. So a lot of the concepts I'm discussing tonight actually might apply to you, but not all of them. So be wary, I focus on migraine, but the concepts may apply to you even if you have another headache condition. Some of these concepts actually apply to any chronic pain condition. So migraine management is complex. It is influenced by a ton of things. Each requires consideration. You will need allies over your journey and medical guidance. My point is that Migraine Canada is all for people empowerment, like patient empowerment. But I hear sometimes from patients that, they like to be empowered, but they also need to be guided and supported. Like we would not expect a patient with other neurological diseases like Parkinson's or epilepsy or multiple sclerosis to take the full lead of their whole condition by being empowered and knowledgeable. So you do need medical guidance. It is a chronic disease. It is often a lifelong journey. Migraine is not something that is curable. Sometimes it does improve tremendously. Sometimes it doesn't. There's no fairness in any of this. And I think it's very important because with any chronic disease, especially pain, can come a significant amount of anger, frustration, discouragement. So it's a brain disease, and there's no fairness as to who responds to a treatment and who doesn't. When we are desperate and in a very dark place, in the hell, sometimes we look for answers in everywhere, anything. And so I also want to say that be aware of pseudoscience and fake claims of miracles because sometimes they can be harmful. And some situations are very tough, but we do have way more options now. So there's really a lot of way more hope than we had before. So let's dig in. What do we mean when we use the word chronic migraine? Chronic usually has to do with time. From Chronos, it's the Greek kind of a god of time. And it means over a long period of time. In migraine, it's a bit particular because we use the term chronic, and I'll tell you why in a few seconds, for a frequency of attack per month. So chronic migraine is a definition where you need to have migraine, a diagnosis of migraine, and you need to have 15 days or more per month for more than 3 months of a headache, of which 8 fill the criteria for migraine. That means that they are accompanied by nausea and vomiting, phonophobia, photophobia. I'm not going to dig into the whole details of migraine diagnosis. Or in a person with migraine, they can also be the headaches that you might be treating. So for example, if you say, oh, I think that's a migraine attack, I take a triptan, it goes away. You never made it to nausea, photophobia, or light or sound sensitivity. It still counts because we know these headaches. You cannot just ask people not to treat to double check that they have migraine. So those are the codes. And of course, you don't want this type of headache must not be explained by another diagnosis. And that's also quite important. So where does that term come from? Just for the history part of it, in the old days, that's 20 years ago, we did not use the term chronic migraine. We used something called transformed migraine because the headache experts at the time, they were seeing people with migraine deteriorating, getting worse, and then getting in that kind of form where you have, mild headache days, moderate, severe, it's mixed. These patients were doing worse. They were more difficult to treat. They were more severely affected, and they had medication overuse and other health issues. So that was called at the time transformed migraine. At some point, and these patients were usually excluded from research because they were so-called too sick, and researchers thought they would not improve with treatments. And so they were focusing on people who have frequent episodic, like 8 or 10 migraine days per month. But then all along the process, there was a time where in the headache community, people were discussing about this and talking about this population of patients. Remember, chronic migraine is 1 to 2% of the world's population. It's a lot of people. And then along the way came Botox. Botox was tried like the other treatments for episodic patients. It did not work. And then the company said, okay, let's try Botox for these patients who are more severely affected. And it worked. And that's why now we have Botox approved only for chronic migraine. So that term was then coined in the classification, the Bible I use every day to diagnose migraine, exactly like I presented to you. And this is a completely arbitrary limit, this 15 days per month limit. It was decided, by experts around the table, not based on statistics or on research or anything. They just said, okay, let's put the bar at half of the day per month. And let's say half of half, that's kind of 8 days with migraine symptoms, since 3 months, because 3 months is in medicine is usually a kind of a very symbolic time where everything switched to chronic or not. So my point here is that those criteria are not really based on science. They're based on consensus. And so what happened is that we doctors, those who know me, I'm a big fan of cats. And so we created 2 distinct categories, okay? Black and white, episodic, chronic, easy. And then we started thinking all or nothing, am I episodic? Am I chronic? And then we developed the concepts of chronification or progression, though progression usually is improvement, but sometimes in medicine we use it for deterioration, where you go from the bucket of episodic, 14 less, to the bucket of chronic, 15 plus. So all the research, all the trials for medications were switched in episodic and chronic. And then we studied risk factors. So research between the 90s and 2000 and now actually still distinguish those 2 categories. But that's the reality. The reality is that there's no 2 categories. Migraine is a continuum. It is a spectrum. And people will not stay in those 2 buckets. There's no scientific reason to keep it as distinct. So migraine is a spectrum. You might wonder what's this little curve there with little dots. Well, each line is a person, and the purple bar is the famous 15 days per month limit. So below is 0, and then you have up to 28 days per month. And so you see that people come up and down. They have good months, they have bad months, and that might depend on a lot of different things, from emotional stressors to other health issues, to just pure serendipity, to hormonal fluctuations. And so patients do not stay in these. It's not white or black. So how should we study migraine? Should we create quartiles, 0, 7, 8, 14, 15, 22, 23, 30? Because we know also in headache medicine that the people who are at the worst part of the spectrum, they have headache every day. These people are another subgroup. They are also more difficult to treat and they suffer more. So how should we study this? It's not clear what's going to happen. And then I'm going to push further based on a question from a member of our community. What is a headache day? What is a migraine day? Because when you think about it, it can be a migraine attack, can be a lot of different symptoms. Some symptoms are not headache, they're not pain. You can have a prodrome, before the attack. You can have a postdrome after the famous migraine hangover. So what was the headache day? Was it mild, moderate, severe? Did it last the whole day? Did I take a medication? Did the medication work? Did the symptoms come back? We manage a Canadian migraine tracker. A lot of people ask us why they cannot put 2 headaches in the same day. And that just reflects the reality that sometimes you treat the attack and then the headache come back. So if we wanted to be super precise, you can imagine we could check at every 5 minutes the state of the symptoms, but it would be just very, very cumbersome. So the question of intensity is very important. When I work with my patients, and this is a patient before and after a preventive treatment, well, if you know the Canadian Migraine Tracker, it's based on kind of headache-free, mild, which is green, moderate yellow, severe red. So on the 6 months before the treatment, you see this person was suffering a lot as most of the days were moderate or severe. There was just a little green, a little mild, and no headache-free days. After the treatment, I mean, this person was still severe chronic, still every day, but there was way more severe, mild green days. So that's also a very important aspect that we do not count. So the conclusion on this intro, if you wish, about the definition of chronic and episodic migraine is that this category does not reflect reality. It does not reflect a scientific truth. And it was just a step forward in our understanding of migraine to recognize the diversity of frequencies, of intensity, and to include everybody in research. Because at the beginning in migraine, a lot of people were excluded, and those people were usually the more severely affected. It is still used. It's still important to know about episodic and chronic, but I think in the new classification, it might be different. But for now, we still have to deal with those definitions. So what will be the next step? We'll see. On one note, so you might wonder, what Migraine Canada does. We offer information, webinars, but we also try to see how to improve care in Canada on a more high level. So ideally, migraine is a disease that is not an infection or a tumor. It's not curable. It's something that we live with all our lives or a long part of it. And so it should be listed as a chronic disease. If you look at chronic diseases in America, cancer, diabetes, epilepsy is a chronic disease, asthma is a chronic disease. So migraine should be listed as a chronic disease at every frequency. And why is that important? It's because if you have this recognition of chronic disease, then it does come with statistics, programs, disability recognition, and also money for research and other policies on the federal and provincial basis. So we're working on this, but I think it's really an important aspect. Okay, so we said that chronic and episodic is a bit artificial, but nevertheless, we mean that chronic is more frequent, more severe. So what is chronification is going from less severe to more severe. And what are the risk factors? It's important to distinguish a cause of a disease that, for example, if you have a bacteria, you remove the bacteria, you have a cure. A risk factor is something that is a cause partially, so it increases the risk of a disease, but if removed, the disease eventually still exists. So for example, vascular health, so stroke or heart problems, we know the risk factors. And there's a lot of risk factors for migraine because migraine is really a disease of the interaction between the brain and the body. And you will see, and they're like, where is she going? Is she supposed to tell us how to improve? Well, it's very important before I discuss how to improve, what is the theory behind all this? So the idea is, yes, the migraine is the brain disorder. It impacts the brain and how it interacts with the periphery, with other things. So the state of the body, the state of the spirit, the state of the environment. And so if to treat migraine, you can improve your load, so decrease your triggers, decrease what is pushing on the brain and triggering the migraine situation. Or you can also stabilize your brain and modify your brain chemistry to make it more resistant. Chronification usually happens over time. It's sometimes we see people who are chronic even in childhood or teenage, but usually the people who are chronic are more in their 30s and especially 40s. And this comes, over the life. So this is a kind of a multi-year, multi-decade process. Um, and I think it's very important that we talk about this because the community, the scientific community, we hope that if we treat migraine better, earlier, maybe even if we start educating children with migraine, teenagers with migraine, young adults with migraine, that maybe they will not chronify, they will not transform, they will not get to this severe stage. So we should probably be more proactive in education about migraine. So now we get into those risk factors. And from the risk factors, you will see come part of the treatments. So I did separate this. Some of these tables, they put into, what you can change and what you cannot change. Of course, you cannot change your age, so the demographic aspect. The socioeconomic status, so might be here, how the income and the in which type of environment you grew or you live. And hardship, is definitely one of the factors. And then you have all the other health issues. Okay, so if you have migraine and you've had whiplash, trauma, concussion, it's usually, then it becomes sometimes a new headache, post-traumatic headache, but it definitely is worse in people who had migraine before, and it can lead to deterioration of migraine. One thing that's very important, mental health issues, all of them. In my clinic, I see depression, anxiety, of course, but I also see ADHD, autism, or the spectrum of autism. I do see patients who've had difficult childhoods, and that some of them might have complex PTSD, post-traumatic stress disorder. Some people have disorders from other events, traumatic events. On the body side, and the body and the mind for me are with the years closer and closer, but obesity is really something that has a great impact on health in general. But in migraine also, we know that more weight, more overweight you are, the more obese you have higher risk of having chronic migraine. And there's many reasons for that. Stressful events of life. Caffeine intake is an interesting one. I mean, we all wish that if we stop caffeine, just migraine could go away. It's not necessarily true, but people who do drink a lot of caffeine are more at risk of having of becoming chronic. Snoring and sleep disorders, sleep apnea, for example, and sleep apnea is also linked with overweight and obesity. And people who have other pain syndromes, fibromyalgia, endometriosis, and so on. And then it turns, fibromyalgia is also associated with adversity in childhood and other pain. So some of these are kind of related. And then migraine characteristic, people who start having a higher frequency are at higher risk of becoming chronic. That's kind of natural. But, when I trained in neurology, we said epilepsy gets seizure, begets seizure, more seizure, more seizure. And that's true for migraine. More migraine, more migraine. The system becomes a more and more unstable, the more and more sensitized, we call it. And with no surprise, and we'll discuss this question of overuse, but sometimes it's a cause, sometimes it's a consequence. So it's very difficult to know which is which. But people who have a lot of migraine attack treat a lot, and that's usually not a good sign. Is it a cause or consequence? It's difficult to know. And people also who do not respond to acute treatment, and we'll talk about this a bit more detail later. A few words about trauma. So neck trauma or head trauma. It is very difficult in the classification at present time for doctors in general to make diagnoses that make sense. Because if you think about it, this life is long, and some people have, a little concussion here that did not cause trouble, and then they have another whiplash that maybe the person started having more neck pain, and then the migraine got worse, and then there was another accident. So often this kind of mix between migraine, cervicogenic headache, the neck is a big thing. We'll talk about the neck later, but the neck is really a big thing. And the neck and trauma and whiplash are related. So sometimes it becomes just this big mixed bag of diagnosis, and it becomes difficult to treat if you try to separate, all of this. So it is a challenge. And just so you know, it's possible if you see different healthcare providers, some of them will say you have occipital neuralgia, others will say you have cervicogenic headache, others might say you have migraine, others might say you have post-traumatic headache, or a big mix of everything. Migraine does not come alone. So migraine is associated. So that doesn't mean that this is the cause. It's an association with a lot of stuff. So on the top, you see insomnia, depression, anxiety. Migraine is a brain disorder. These are also brain disorders. But then you have other things. For example, asthma, psoriasis, osteoarthritis, and vascular risk factors. So when I meet a patient, and if if you want to look at your own situation, probably you've done it already, your global medical history is very important for two reasons. Well, first, because there are some drugs that you cannot take if you have one of these conditions. And on the other side, there are some drugs that might actually kill two birds with one stone. So sometimes we will favor drugs that might, for example, treat epilepsy and migraine at the same time, like topiramate or valproate. Or if you have hypertension, then you might take something for blood pressure. That's also good for migraine. This being said, sometimes, well, we want to give a blood pressure medication and then the person has very low blood pressure to start with. So that becomes a problem. So when I see people with chronic migraine who are difficult, they are struggling, very often there is a list of comorbidities, of other diseases that sometimes play a role. They might play a role on the inflammatory aspect, on the metabolic or energetic aspect of the body. They might play a role on the pain system, if there are other pains feeding in the brain. They might play a role on the brain itself, if we talk about anxiety or depression. And then they might play a role also on the vestibular, for example, system. I see a lot of patients with vestibular migraine, and sometimes it's complicated. These patients can have, BPPV, or which is a benign postural paroxysmal vertigo. And then there's a subset of patients who have respiratory problems, inflammatory or allergic problems. So that's very important. I'm kind of a social doctor, I like to think in terms of systems and networks. And if I look at, health, the determinants of health, there is recent research suggesting that pollution is actually now the number one driver of vascular health in the world. Maybe not if you live in a nice forest with a lot of nice air, though now, there's a lot of fires, but um, it's very difficult to kind of disintricate all of these drivers, those determinants, where you live, in what type of environment, climate change, your workplace, and all of those basics of the system where you grow in. And then the risk factors. Here it's a graph about vascular health. So, your diet. Your diet is not only what you decide, it's also what society puts in front of you, right? Sedentarity, lack of activity. Well, it's easy to say someone is not training, but we know our society is very sedentary. So all of those risk factors play a role in all of those other chronic diseases. And I think they also play a role in migraine. And some people have all of this together. And so we have to see this in a more global aspect. So to sum it up, before we actually move toward ideas of improvement, those are what I call the vicious circles of chronic migraine. Someone is born with migraine genes or a migraine software, a migrainous brain, might have occasional attacks. And then sometimes something happens. Can be a lot of things, an accident, an hormonal change. I put perimenopause, but it could be a pregnancy, stressor, another disease comes in, a surgery, whatever. And then attacks increase. And then the cycles, the brain is destabilized. The person starts having insomnia, anxiety, depression, difficulty struggling. And sometimes, it's stuff at work, it's stuff in the family. And then people tense up. Today I saw, I don't know how many patients who had this kind of jaw and neck tension related to chronic pain and anxiety. And then you start kind of, you cannot cook anymore, you cannot train anymore, everything becomes more struggling. And then you start drinking caffeine and taking more pills because you need them. And then you get into this vicious circle. So this is kind of the bad circle, but the good news is all of those things are things we can act on to reverse the chronic status. It's just trying to find which button or which lever to pull first or in what order. This is a slide for doctors. It's not something I usually present to the public, but I think we should consider as we close this chapter of definition and concepts, um, could we use a predictive score? Beyond this kind of a bit stupidish thing of chronic episodic, could we just look as they do in the psychiatry world and say, okay, what's your diagnosis? What is your map? What is your medical comorbidities? What is your mental health aspect? Where do what are your social factors? What is the impact on you? And then we build a plan. For example, here I have a 42-year-old lady. She has migraine with and without aura. She has status like long attack, status migrainosus. She has asthma, allergies, obesity, a bit of anxiety, panic attacks, but not anymore. She works full time. She has private coverage to access drugs, something very important too, we know. And this is a score for function. And from this, we go forward, we build the plan. Okay, so now this was kind of the, setting up the stage. So we understand why I'm going to make the recommendations or the chapters. Each of those kind of green things, sections, is a full chapter in a book. The time does not allow me to go into great depth, about which drug you should take or how you should take it. But I want to just present the chapters to you. And those chapters are things that I see in my office today. I saw them in my patients. The first here, and also I'll just give you a hint about how Migraine Canada is trying to improve things for you. So the first thing is, get a competent healthcare provider. I have to say this. I mean, I think it's a bit unfair to people to ask that they treat themselves. I mean, it's very important to be involved and to take care of yourself as much as you can. But I think having an ally is important. So, what is a good healthcare provider? This person can be a primary care provider, a neurologist, can be another specialist, can be, and then you have also other allies. So, this person should take a good history of you, uh, be organized a little bit, listens to you, recommends a headache diary. If someone does not mention a headache diary in this field, I would say it's a bit particular. Includes you in the decision, does not make the decision for you, proposes things, and then listens to what you want to say or what you think, answers your question. I hear there's a lot. We're all dead busy in our offices, but if you have questions and there's never time to answer your question in management of chronic disease, it's not good, and does not blame you, for things. Now, of course, if there are recommendations and you commit to something and it's not done, well, there might be a discussion on why and how, but you should not feel shamed or guilty or blamed. I see a lot of my patients, they tell me they've seen doctors and they left in tears because they were told like, why aren't you doing anything and it's your fault and la la la. So that's not good, right? You would want someone who's your partner, who's your supporter, not someone who makes you feel guilty. You should get the right diagnosis. So obviously, is it migraine? Is it post-traumatic headache? Do you have other things? And then you should start the headache diary to make this more precise than episodic or chronic. Um, I want to pitch for our Canadian Migraine Tracker. This is an app that we created with the Canadian Headache Society because we were told by people that migraine body was too complicated and too heavy on the long term. So we decided to create something super simple. And I invite you to try it, or you can check on our YouTube. There's a YouTube channel to explain to you a few things about how to make the best with my gracious person. So you can go and learn how to use the app. And you can see, I mean, it uses this kind of tree level, it's not perfect. It might not fit for you. You might always use another type, paper, app, whatever works. But it's very important to get a diary because especially when you have a high frequency and there's a lot of different intensities, a lot of different treatments, Without a diary, I'm not too sure how. Sometimes we take a break. Today I had two patients, they were going through a lot of hardship and they took a break from their diary. Perfect. But usually, it's very useful. And then what I presented to you, what we healthcare providers do, I think it's probably a good idea that you have your own map and you are aware of the different factors that you could work on, to be aware of, what your attacks are. Is this clear or not? What is your help, what, and it might seem really easy, but I sometimes I build those stories with my patients, and we make links when as we build a story about what happened, in the body and the mind, in the environment. Be aware of your triggers. I'm usually not a great proponent of watching everything all the time, but at some point it's good to make this work and have an idea of what influences you, and then build your own map of what you've tried. I see a lot of people, they come for the consultation, and this is universal for us headache specialists. And patients will come to us and they will say, "Oh, I've tried everything." And usually it's not true. Usually they haven't tried everything. So it's so helpful to have a list of the drugs you tried, the preventive, the acute, and also, the other things that you've tried. Have you tried physiotherapy, massage, hypnosis, whatever else? So to have this somewhere is tremendously helpful to also see, what you haven't tried and do you want to try it? So one of the first thing when we build a plan, once the diagnosis is clear, then the diary is there, is to adjust lifestyle. And as you see, I see adjust. You cannot modify the whole thing, right? And there's usually two levels. I could give a full talk only on this line for each line, and I will not do that. But this table I present to primary care providers to explain to them that some people are beginners. They are starting, they haven't tried a lot of things, and they can definitely benefit from basic advice. And others, and I suspect a lot of you listeners are in this category, they have done a lot already. They have read a lot, they have tried a lot. Sometimes they have been disappointed a lot. And then you go into the world of, other allied health cares, nutritionists, physiotherapists, kinesiologists for exercise, different types of therapists. And I'll go a bit deeper on that aspect. And the occupational therapy, as I sometimes recommend as well. So, what is your personal list of things that are realistic, feasible, accessible, affordable? And I can tell you, I see patients for now 15 years. It's a path and it's a journey. And sometimes, you need a village and you need allies, and you cannot do it all at a precise time or at the same time. So that's also that's just a useful thing. A few words on therapy, because this, first of all, remember, I didn't get 1 second of training about therapy when I was in neurology training. It's very weird, but that's what it is. And I'm not too sure it's different now. Because usually when we talk about CBT, cognitive behavioral therapy, there are many different types of this. Usually it's to address your thoughts and to look at them, and then to work, to behave differently, to reflect, and to try to move away from the negative to the positive, because our brains are just geared to be very negative. That's a survival thing that dates back million years ago. We cannot do anything about it. And so there's a lot of things that can be done in CBT. But CBT is not the only type of therapy that can be done, okay? One word about talk therapy. Sometimes my patients, they go to see a therapist, and no offense to any therapist, but I say, "Okay, what do you do with the therapist?" And they say, "Well, I talk to them about my week, and they asked me about my childhood and all of this." Okay. But after a few years, it becomes a place, sometimes you need to vent, to get support. That's perfect. But does it lead to change? Does it lead to improvement? And sometimes what I've seen is some of my patients, they go to therapy, they just reinforce their patterns because they repeat the same things over and over again, but there's no attempt at changing for the better. So it's just a little word. Sometimes therapy can be good. Sometimes it's just keeping you in your patterns, not necessarily ideal. There's so much stuff in therapy. Okay. I've seen people, they have seen one or two therapists, they hated it, and they said, no more therapy for me. Well, it's difficult. It's tough to find therapists. They are expensive. It's a big investment of time, effort, and money, but it can pay off. For example, sleep CBT for insomnia is something that's extremely powerful, but it's difficult to find and it is expensive. Dialectic behavioral therapy is usually more for people with borderline personality, but that's something that exists. There are all kinds of approaches for post-traumatic stress disorder. Acceptance commitment therapy, or ACT, is something tremendously important in chronic pain. I discuss about this with my patients. I have a few books I recommend, and it is really something that can help. You do not need to do it for years. Usually in a few months, you can already be trained in basic principles. Pain reprocessing therapy is a bit different than ACT. It's actually something that's shown a lot of promise in low back pain. And it's something that is growing now. Art therapy. I've sent patients to art therapy, and sometimes it's just the key. Dealing with chronic pain, and it's actually sometimes if you revive something that goes in that very soft, very joyful part of you, it's not going to take the pain away, but it will support you through it. Hypnosis. I've sent some patients to hypnosis to great success. Not all of them, um, but it's something interesting. EMDR, or eye movement desensitization and reprocessing, is something for post-traumatic stress disorder. And then there's a new thing, a new kid on the block, if you wish, that's called FND, functional neurological disease. It's usually more motor, like people who have tremors and stuff, but it might apply to some people with pain and with, for example, chronic Lyme or chronic fatigue syndrome. Fascinating area, very complicated. What sometimes makes me a little bit sad is people tell me, well, if I didn't have migraine, I would not be depressed. And it's maybe true, but it's bidirectional. So sometimes people also live with depression and anxiety disorders, and migraine is not the only key. So I would say just target everything, right? It's usually not a good idea to say, well, if when I never have migraine, when migraine is gone, then I will be perfect. It will be okay. That's extreme. But don't underestimate the importance of taking care of mental health. Meditation. I could give once again a full webinar on meditation. I practice meditation. I play with it. I'm still very beginner, but there's so many different ways. Cardiac coherence is a good way to start. You can find tons of YouTube videos on it. Breathing practices, there are tons of them. It's all about doing it. If you're like me, you can look a lot of YouTube videos, but looking at the video is not enough. You actually have to do it. Just basic meditation, Buddhist meditation, mindfulness-based stress reduction is usually an 8-week program that can be extremely good. Today, I recommended the progressive muscle relaxation of Jacobson. That's a very interesting German thing where you clench and declench your muscle. Very good for people who have this kind of tension and anxiety circle. Practicing self-compassion, gratitude, expressive journaling. So this is really a path of many years, many books. And if any of these words you don't know or you haven't explored, maybe there's something for you there. In my clinic, I have my multidisciplinary team of books because I don't have the privilege of having, an occupational therapist or a psychologist or working in the clinic. So I built my little list of books. There are many. Those are, I would say, some that I really recommend. Body Keeps the Score is about trauma. Another about trauma is Pete Walker, Surviving and Thriving. The Way Out is the companion book to the app Curable, which sometimes is actually quite effective. It's based on the acceptance commitment therapy. There are some masters of meditation. Pema Chodron is someone who's amazing for just kind of more philosophical Buddhist approach. Is this going to cure your chronic migraine? Absolutely not, but it might actually help you manage the ordeal. Okay, so this was for behavioral and lifestyle. Now we move to drugs, medications. We have a lot of information about drugs and medications, and those can be prescribed. Here, I just have one slide about acute treatments because we have other resources for this. But just to say that optimizing acute treatment is key. So that means that ideally, you would have ways to treat your attacks properly, and there's a lot to be tried. We still advocate in headache medicine to avoid at all costs, and I know this is a heated debate on patients' forums, opioids and barbiturates, for example, Fiorinal, because of the high risk of chronification and deterioration and side effects and addiction. Now, there are people who fare well with opioids and barbiturates. There are a minimal subgroup. And if you want to discuss this with your provider, I think it's a good idea. But my point is, don't be surprised if your provider just says, I don't prescribe opioids for migraine, because that's what we teach day in, day out. That should be a very last resort. And I have to say, even the best clinics in the States now, they do not prescribe opioids for migraine. So that's something we could discuss more, but it's still a rule. GPANs, so that would be Nurtec and Ubrelvy for acute, are really a welcome addition because they have no risk of medication overuse. So if you do need to treat often, you might want to try these new options. Switching now to the world of prevention. Okay, so I don't know here, there's more than 100 people out there, so I'm so glad. I don't know your story. I don't know what you've tried. I have no idea if the people on the line, have tried 1, 2, 3, 4, 5, 10, 15 preventives. I bet most of you have tried a few. But here are the new guidelines for prevention that will be soon out. This is not the final publication. It's kind of a preview. But overall, what's going to happen is there will be 10 medications that will be strongly recommended for migraine prevention, episodic, and one for chronic, which is Botox. So episodic and chronic. So the big thing is that topiramate, Topamax, is downgraded to a weak recommendation. Candesartan, which is a drug for blood pressure, is upgraded. So, and all of them are on the same equal foot, right? So the message here is if you haven't tried CGRP medications or toxin, keep hope, my friends, because those can really change the life of a person with chronic migraine. We have webinars and PDFs on all of these. So if you haven't tried the kind of second generation treatments, you should definitely try them. Now, if you have tried all of that, there's definitely other options, what we call weak recommendations. In case of, because either they are poorly tolerated or they have more risk of side effects. And then what we will need for research is what will happen, are these drugs useful for someone who has not responded to a CGRP antibody, a GPAN, the toxin, combinations. And so those drugs, some of them are older drugs, like, for example, Epival, Devalproex, Pizotifen, very rarely prescribed. Some are newer, like memantine, for example, is something we give for Alzheimer's. You can see topiramate will be in that list, venlafaxine. So there's a lot of drugs. I mean, there's 10 on the previous page and then 11 there. So that's 20 drugs that are on guideline by the Canadian Headache Society to prevent migraine. And all of these can be, increased or combined. There's a lot that can be tried. But now, this being said, the first 10 ones are the ones that have the strongest evidence, and those ones are those with less evidence or more risk of side effects. If you haven't tried a CGRP drug, I have to say, this is changing our world. This is changing my world. This is an example, 2 diaries of patients. And I'm sorry, I just realized I didn't remove the name of the patient. But so here, this patient is happy with 3 migraine days per month or 1 instead of like I think she had 15 or 16 per month. So great response to a CGRP antibody here. Ajovy. It can be any, they're all good. And then on the other side, you have the Canadian Migraine Tracker data for a patient who had a partial response, went from 14 to 14, 12 to, 5, 9, 6, 7, 3, and going. So if you haven't tried one of these, or many of these, actually, I mean, it's worth trying many, or try them all. I mean, I try everything in my clinic. It's worth trying, definitely. You can also respond partially. I mean, it's sometimes this is the patient I've shown you before who is also on a CGRP antibody. It could be also a GPANT like Ulipta for prevention. Sometimes people respond and they are very happy to have at least a partial response, right? Because instead of being moderate or severe all the time, they move to this kind of mild category. And that's already a little relief. And sometimes after years of trying, it's okay, at least we have this response. It's important to make that understood to insurance companies, though. So the partial response, sometimes, we all wish we could have a super response, but sometimes we have a partial response. It's not only frequency, it's how you can tolerate triggers. How can you plan your activities? Do you have better mood, better sleep, a better response to acute meds? A lot of people tell me when they respond partially, they say, well, maybe I still have a lot of migraine days, but my triptans work, or my GPANT work, or my NSAID work. I can control most of my attacks, as before I was, I had to go to the emerge, or I was missing my work, or I was just lying in bed miserable all day. So that's very important. So we should not kind of, hope for the super miracle of a super response. And sometimes a partial response is already something good. On the other side, super response has also, made us reflect, because a lot of my patients who have tried years of stuff, years of, meditation, drinking tons of water, doing yoga, cutting everything from their diets. Well, after all, I give them an antibody or a GPANT, and wow, miracle. So it makes us think there's probably subgroups of people with migraine. There are people that if you block their CGRP, it goes super well, and that's great. And there are people where you block their CGRP, it does nothing, and maybe the key is elsewhere. So I think we should really reflect about, how long and how much we should push on people to change their whole lifestyle because they have migraine, when maybe you can treat them, and some of them, that's all they need. We cannot guess who's going to super respond or respond to any drug for migraine, but that's definitely something that, like, oh, you can do it, or yes, you can be empowered and manage your stress. So that's a fine line when we deal with migraine, how much you can really control and how much you should be doing to deal and cope. If you don't find a treatment, is there a new treatment that could help you? So the other thing I want to share with you guys is something I try to share, things that are relatively consensual in our world of headache specialists. Most of my colleagues will agree that if you have severe refractory chronic migraine, you want to improve, the combination of the toxin, Botox, with a CGRP blocker, an antibody, or a GPANT might be the future, because they actually combine, they have different mechanisms of action. This is a tango, this is a tango with the insurance company, usually because you have to prove to them. I showed you a little table of, what I usually build up with my patients. So at baseline, what's the frequency, moderate, severe, the hit scores, the function. And then we have to prove treatment 1 works enough, but not enough. And then treatment 2 works and the combination. It's complicated. But tonight is about, what can be tried. This can be tried. And definitely it's an interesting approach for the future. Oh, I put here the Canadian Headache Society has written a letter, a 4-page letter that you can use to appeal of your insurance companies. We do have access to this at Migraine Canada. And if you need, your doctor to be supported in writing appeal letters and discussing with your insurance, that's definitely a document you probably need. Okay, so now we have our steps. We've discussed already a lot of things, lifestyle, acute, prevention. What about overuse? Just this today, we had a lunch and learn with our team of headache where I work. We discussed cases of medication overuse. So that means person with chronic migraine who's using frequently. I don't like the term overuse because it's like a bit judgmental. But anyway, overuse or frequently different drugs, triptans, Tylenol, Advil, opioids, Fiorinal, a mix of all these things. And the key concept. It's a key concept I try to teach to primary care providers, pharmacists, neurologists. It's impossible, it's very difficult to predict in a given person with migraine if the overuse is a cause of the chronification or a consequence. I mean by that some patients, you treat them with toxin, Gpan, topiramate, Botox, whatever, antibody, and then they don't overuse anymore because they don't need these drugs anymore. And then you don't need to withdraw. People just improve. On the reverse, some people who overuse, you give them your best. You try drugs and prevention. It doesn't work. And what you need to do is to stop the overuse and organize a withdrawal. So the point is here, does everybody who uses a lot of acute treatment need to withdraw to improve? The answer to that is no, but some people definitely do need. I just recently saw a lady of 75 years old. She was on Fiorinal every day for the past 40 years. She had tried to withdraw. She withdrew, it didn't work. But then I gave her an antibody, Vyepti, and she did withdraw. I mean, so the first shot of Vyepti didn't help that much. And so we planned a second shot, the second IV. And then she did decrease her Fiorinal, one little quarter at a time over a month. And now, is she cured? No, she's not, but she has 8 days per month treated with almotriptan, and she's a happy camper. And when she goes back to Florida, she's going to have way more fun than when she had her daily migraine with like the Fiorinal every day. So overuse is a problem. It's complicated, and definitely it's something that you need to discuss. So that's actually this lady. Here we are, 40 years of daily techno, very, I mean, diary, very clear. So you look here in August, you can see she's taking her Technal every day, almotriptan occasionally, and then she has her first dose of Vyepti, and then she decreases her Fiorinal, Technal, and then it all improves. And here you are with very nice diaries with way less headaches. All right, so now we switch to another chapter. I have to say in my clinic, when I see a person with chronic migraine, often I talk about the neck and the TMJ and the mental health. Those are the two kind of big zones that I usually discuss. So I've learned a lot on this over time with the help of my patients, and I want to thank them because they teach me everything. Nobody told me any of this in neurology training, just so you know. It's something that we do not learn in neurology. And so you will find some doctors who are really interested in neck pain and others who do not want to get involved in neck pain management. And that's okay. So if your neurologist is not really interested in neck pain or doesn't know what to do, you might need other healthcare providers who can help you. So here's a few things. It's just kind of a mixed bouquet of things. I'm not going to discuss any of this at length, but it's just a few concepts. Imaging is rarely useful. A lot of my patients, they say, oh, what about MRI, CT scans? MRIs, we do them, we see something a bit of arthrosis, a bit of crunchy facet joints here and there. Very rarely useful to manage. The only time where it's useful is if you need to call the surgeon because the spinal cord is compressed. That's extremely rare. So I would say it's okay to get imaging, just don't expect too much from it. The osteopaths and chiropractors, okay, they help a lot of my patients, but often they will focus on an idea that there's a misalignment that needs a correction. That's not really based in actual science, despite all they will say. And the only way to actually change the balance of the spine is to reinforce muscles. Passive manipulations are not the key long term. And so nerve compression is also rarely the issue. And so it's very difficult to evaluate the neck properly. Okay. We don't have perfect testing for this. We can palpate, we can massage, we can, feel tenseness, we can do an MRI. But at the end of the day, God, it's difficult. And I cannot claim, that I know exactly what to do. So we try, but the missing piece is often muscle strengthening because painful muscles usually need strengthening, not only stretching or passive manipulations. And the only way to strengthen a muscle is to activate it, and only you can do that. It takes time, it takes help. Now you're going to tell me if I do exercises, I have terrible pain. That's possible. That means you need to go on milder exercises, very progressive. It's a lifelong process of coping, but there's definitely something there that often my patients haven't tried for all kinds of very good reasons. So cervicogenic headache, this is something I use a lot when I present to doctors. There's not only, there's the muscles, the bones, the roots, and then the brain that puts all this pain together and all those sensations together. And all of this can be managed, with massage, manipulations, exercises, trigger point injections, acupuncture, Botox, facet blocks, all kinds of blocks, injections, and then medications and pain reprocessing therapy. So it's very complex. And I have to say, in my clinic just today, I would say half of my patients had neck issues, and we had to find a way to try to move forward on that front. Another point here, and this is kind of the modern, this is me probably on a daily basis, approximately. It's very, this is just how humans are now. And it's not only the neck, this is the whole thing. So usually I'm a big fan of trying, to keep a better body. It's very tough. I'm all for walking and stationary bike, by the way, but it's not going to build your arm and neck muscle. It's great to walk. I'm not saying don't walk, just saying it's not enough. So what I often recommend kinesiology, so working with a trainer to find the right exercises. A lot of kinesiologists now actually are trained in chronic pain management. Eccentrics is great. Look it up. Qigong, Tai Chi, Pilates, dancing, if you like it, can be great. Stretching, any movement to address all this kind of spinal problem that a lot of us have, and that will not be corrected by any passive manipulation. We're getting close to the end now. That's a very important thing, dear to my heart. A lot of my patients are living with hardship. A lot of hardship can be a difficult relationship, sometimes an abusive relationship. It can be a loved one with chronic illness. It can be a kid with autism, a loved one with addiction or mental health issues. It can be an elder person having their loved one sick or even dying. Today, one of my patients lost her husband last week, and the other one is dealing with the Alzheimer's of her husband. Another is dealing with a severely ADHD and autistic kid. Sometimes it's the workplace. That's horrible. It can be, I have a few Ukrainian patients, they're enduring, having their family in Ukraine. That's something they have anyway, so hardship, true struggle, that contributes to mental load and chronic stress, and that adds up. And sometimes it just is too much and for the migrainous brain. And that's why I put this person here, just carrying this heavy load. And in these people, sometimes when I deal with patients like this, I just try to support them. It's very difficult, but I just want to acknowledge this. And please, if you are abused or threatened, try to get support and safety. And I address especially to women or men, but usually it's women who might be in difficult situations. And so then the question is, are there people who cannot improve? All right, well, there's nothing else to do. This is one example. And I think it's important to recognize that sometimes things have been done. This is a lady of 54 years old. She has chronic migraine refractory to everything. And in her case, I can say everything. Interestingly, she doesn't have any neck issues, no accident. She has some insomnia, depression that really seems to be caused by the migraine. She's seen 7 neurologists, best doctors, 2 neurosurgeons, 4 pain clinics, 3 psychiatrists. She's tried the whole gamut: shaman, Reiki, hypnotist, naturopath, psychologist. She's done every diet possible. She's tried all of this, and that's roughly the whole cookbook of migraine medicine. She's even had implanted occipital neuromodulation, something that's not recommended for migraine, by the way, usually. 2013 and 2017, she has transcranial magnetic stimulation, very rarely used for migraine, very difficult to access. IV ketamine, very rarely used. I do not recommend. She's had all this and nothing worked. And so at this stage, I have to say, for this person, I think like she will have to live with whatever is there. I think there's nowhere on the planet where there might be a treatment that science is endorsing that can help her relieve her headaches. Why is it the case? I don't know. So why are some people very refractory to treatment? It can be, we talked about CGRP, could be other peptides, could be metabolic pathways. There are all kinds of chemistry things in the body we don't yet know about. Other medical problems, other mental health problems. We talked about the hardships, uncontrollable neck issues. Some maybe the brain just chronified and you cannot improve it. And some pain control mechanisms. There's a lot of possibilities. But what's really nice is that like it's less and less now that we have more approaches and of all kinds, blockers, antibodies, toxin, behavioral modulation, a better understanding of migraine. If you are in the dark pit of hell, and some of you are probably, and you're trying to find relief. So first of all, you're absolutely welcome. It's normal that you're trying to find relief. Everybody in your situation would do everything to find relief, right? But as a doctor, it is my responsibility to keep you safe from harm. And so usually there are a lot of things. Believe me, there are people out there who know that you are desperate and they will try to sell you stuff. Okay. So it can be surgeries like migraine surgeries, usually not endorsed. There's a few exceptions, but not endorsed for migraine by most headache experts. All kinds of funky devices that promise you'd hear this and that. I have patients who paid hundreds and hundreds of dollars in naturopathic treatments, miracle diets, manipulations, like I said. And then also the testing world, imaging, trying to do lots of blood tests with no real reason, fishing for heavy metal intoxication or chronic Lyme disease, or neck imaging. I told you, very limited importance or relevance. And then, of course, if some of you here have had diagnosis with proper testing and found something, it's great, but it's just a little warning there. So if you find something of interest, right, does it make sense to use it? Is it safe? And how much does it cost? Can you afford it? And who recommends it? So I think that's the idea. So when my patients want to try stuff that is, off the box, I look at that with them and I try to say, okay, does it make sense? Or could you be harmed by this? Is it completely insanely expensive? And sometimes they will try, and if it works, that's great, but just be careful. But there are many options to treat. I think this is kind of a list. We have guides on our website about this. There are many different sources you can use. So there's a lot. And so there's more hope. I finished with, the extreme situation of somebody who could not be helped. But I would say the vast majority of my patients, we find something to help, to relieve partially, or at least to cope. And I think that's very important. So back to our concepts as we close. So each person does need a personalized plan, and you need a medical guidance to do that usually. It's complicated. It's influenced by a ton of things, which each requires consideration. And as you've seen, mental health and neck pain or TMJ pain and sinus pain, I didn't talk a lot about those, but they are also sometimes key. You need allies. It is chronic. It's a lifelong journey. It's not fair. It is a brain disease. Be aware of pseudoscience and fake claims. And sometimes it's very tough, but we definitely have more options now. And there's also research going on. All right, so we're here to help. What we do at Migraine Canada is to make this accessible to you guys. So the app was created to help you monitor your headaches. The list of headache clinics is there to help you find you a specialist. It's growing. We have all our PDFs, podcasts, webinars. We try to make it clear for you. Our website will be fully updated and renewed in the next 2 or 3 months. So look it up because we've had some comments saying that information was tough to find. So we heard that loud and clear. We do advocate for access to care coverage, but also access to better trained healthcare professionals in partnership with the Canadian Headache Society. And we also work on workplace awareness to try to improve understanding of migraine in the workplace and putting in place policies to support people with migraine. So this is our amazing board. Missing from this picture is also Malak, our social media responsible person, and Katie, who you've seen tonight, and also all of our volunteers, our summer students, and people who app manager, website master, all our team.